So Dr. Manjula Peiris needs no introduction. He is a consultant surgeon at Teaching Hospital PeMSAA and he's a senior lecturer at our own faculty. So for the formalities, I will give a brief introduction. So Dr. Manjula Peiris passed out from the medical faculty of PeMSAA in 96, 97. He was a batch of 96, 97. And he had an excellent academic career as a medical student. He has obtained distinctions in physiology, anatomy, biochemistry, microbiology, parasitology, and pathology, and he has also won the Bakuma Kulasinga Memorial Award for surgery in the final MBBS examination. So after passing out from the medical school, he pursued his career in general surgery and he obtained a MD in surgery from Postgraduate Institute of Medicine, and he's also a member of Royal College of Surgeons in England. I will not elaborate on his further qualifications, and I will hand over to Dr. Manjula Peiris to carry on with today's topic. So it will be wound care, new techniques and methods. So I think he's the best person to talk about this topic because he has an interest in wound care and about his recent advances. He's the best person to talk about it. So over to you, sir.
Thank you very much. I hope you can hear me clearly, Kaushika.
Yes, we can hear you, sir.
Oh, thank you very much. Shall I share the screen now?
Yes.
So this should be the presentation. Can you see it now?
Yes, sir, it's visible.
Okay, so actually a slight change in the topic because it's wound care within inverted commas, new materials and methods. So the word new is actually a kind of a misnomer to start it because none of these things are new, except that, what I want to do over the next, few minutes or hours is to put in perspective some of the newer materials which are available for use, and then I want to kind of critically analyze. It's an unbiased kind of opinion, my personal opinion, after using them for about 4 or 5 years continuously in a large number of patients. So I've had the fortune to be able to use some of these materials which are there in the market. So a little bit about me as a presenter. My only sort of qualification for giving you this lecture really is the fact that I do a lot of wound care as a personal interest. There is no such, there are no wound care surgeons as such because nobody's, very interested in wounds. It's a sort of backyard of surgery, right? But, and it's not glamorous and it is smelly, it stinks, it's sweaty and nobody really likes it very much. But for some odd reason, I seem to have developed a kind of a liking to it. So over the past 5 years or so, I have been getting a kind of a continuous stream of patients of varying types. And I've had the fortune or misfortune to be able to use some of these products. Now, the second thing is about the wound market. Now, I call it the wound market for this reason that the wound care, unlike any other field in surgery, is actually an open marketplace because a lot of money is going in, both public sector and government sector all over the world to try and get over this problem of chronic wounds. And as such, there are lots of players in the market. There is a lot of demand and of course there is a lot of supply as well. So most of the evidence we have to prove that a particular dressing is better than another dressing or a particular method of treatment is superior to another is generated by a lot of people who are market drivers, as it were. There are some major big companies who are involved in it. I have nothing against companies as such, but and there are some major players in the market who tend to kind of drive the wound care evidence base as well. I find that the evidence base is sometimes skewed. And if you really go and look at some of the evidence in the big collaborative databases, the evidence gatherers like the Cochrane collaboration and all that, if you just Google up certain things about wound care, you will find that there is no real concrete grade A evidence about anything. Like, for example, you can't have a randomized controlled double-blind crossover trial on most of these wound care products for two reasons. One is that you can't, you can't double-blind that kind of thing, and because again, the assessment methodology for wounds, even to date, are a bit vague. One wound which looks to be healing to one individual doesn't seem to be healing to another individual, and so on and so forth. Lots of assessment methods have come through, like 3D cameras, stereo photogrammetry, and all that kind of thing, but none of that is leading to proper evidence. So for that reason, it's a market-driven evidence base. So, and in such a market, the players include a whole host of wound care nurses, and in the West, a lot of wound care is done at their level by consultant nurses. I mean, they're very good. I mean, even in Sri Lanka, lots of wound care is done by the nursing staff in hospitals, as well as sometimes in the private sector with or without licensing, I don't know. But they are the key players in the market. Less often, a number of general practice doctors, GP doctors at their level regionally have become famous for wounds because of interest and because of again, the market demand. Some people like to move in full-time into wound care practice. So here we have a whole host of people who are interested. Not so much the surgeons, because surgeons prefer to have a one-off event with a surgeon or a patient and get a quick response and then go home nicely back to their cozy homes. But here this involves a continuous process of seeing the patient every third day, like gardening, you have to see the patient again and again. And there's a lot of work involved, even to get a basic wound to near completion or near closure. It takes months and sometimes years. So, and the target audience for this lecture, I hope, is some. I see that the members of the PeMSAA, as well as I've invited a couple of people who may be interested. And of course, I'm targeting the GP population as well as interested nurses, if they are, if they like to discuss their experiences with me, and as well as some of the medical students, if they hope to join. So here we are. It's a low-level lecture, and I just want to confine myself to the products, the materials, and the methods only, because wound care is a huge field. I've trained in breast and breast diseases. I've trained in colorectal. I've trained in all kinds of surgical fields, but wound care is something enormous and very challenging. So ended up getting there. Now about materials. Let's see. Materials. I would like to discuss the disinfectants, the dressings, the common types of dressings available in the market or available in the hospital, as well as the antibiotics, the use and misuse of antibiotics in wound care. The methods, there are some of the more widely used methods like the VAC or the negative pressure wound therapies, and the less well used ones like the hyperbaric oxygen and the laser therapy and radiofrequency and plasma therapy and all that kind of thing. I'll just touch on those. So at any point, if you feel that you want to interrupt, please let me know. I'll just interrupt a little bit to get a kind of a feedback from the master of ceremonies. Dr. Kaushika, can you hear me and see me well?
Yes, sir. You are clear, sir, and your presentation is also very clear.
Oh, okay, thank you so much. Right, so I will continue. At any point, please feel free to just chip in and answer. I don't think we have a huge number of participants as such. How many people have joined, Kaushika?
So far we have 66 participants, sir. But sometimes these students connect with one device. About few students get together and connect to a single device. So maybe the participant number is
so I'm getting more than 5 or 6. So that's good. So I'll have to do a little bit of a better job. So there we are. Try to keep you awake over the next few days. Grab your coffee. So now to talk about disinfectants, detergents, and solvents. Now, I have to make a distinction from the start. Now, disinfectants, the definition but disinfectants, they are usually water-based or alcohol based or some solution, usually a solution, sometimes rarely a gel, right? Which reduces the bioburden, bacterial bioburden, or the potential for infection. And I'll go into some of the commonest ones, right? And detergents, on the other hand, are your soaps. Now, what does the detergent do? It emulsifies fat or greasy substances or non-soluble material. Water insoluble materials are brought into suspension or a soluble form. So certain disinfectants are detergents and vice versa. And of course, on the other end of the spectrum, non-water-based solvents are also there, like ether. And if you go to 100% ethanol or isopropyl alcohol, that becomes a solvent as much as a disinfectant. So it all depends. I mean, those are meant to dissolve sometimes hydrophobic molecules or and such. So essentially, you have three groups. So you have to kind of mentally make a distinction between those three types of chemicals. Now, disinfectants are mainly used for cleaning the wounds. When you open up, you have a wide array of materials like saline to irrigate, cheap and effective. And sometimes you have things like Savlon, which is cetrimide and chlorhexidine. Now, in that, cetrimide is a soap, it's a detergent, whereas the chlorhexidine is a chlorine-based disinfectant, right? Chlorhexidine. And chlorhexidine pure, in its pure form, is used in things like Hibiscrub or Hibitane. I will discuss about that. And these are usually meant for cleaning wounds. Sometimes we end up using solutions of EDTA, like the emulsifiers and detergents, like even if you have a chronic wound, which is already colonized with bacteria, which is already, there is a trend now towards using just water, tap water even. And sometimes some people choose to use chlorinated tap water. And there are certain solutions which are based on chlorine containing water, the hypochloric acid and chloride, the derivatives of that in plain water. Cheap and effective, and it is no longer considered tissue toxic to use water, particularly in an advanced chronic wound. I wouldn't use that in a fresh wound or a surgical wound, or where there is a potential clean contaminated wound. I would never touch tap water into that. But something that has been going on for years and years, you really don't need to force a patient to go and find sterile substances to go and clean it on a daily basis. Again, it is used for disinfecting instruments, linen environment. Now, you know that phenol solutions were used by Lord Lister, the father of modern surgery, who used a kind of a phenol spray to disinfect everything from the nurses to the linen, to the instruments, to the floor, to the ceiling. He even had something like which could spray himself also with it, right? So stemming from that, we use the antiseptic methods of surgery by using disinfectants and such on linen and instruments. And as such, it stems from that a wide range of inorganic disinfectants are used in commercially available proprietary dressing materials. Now, they are easier to manufacture and they are easier to market and sustain in the market because they don't, unlike bioproducts, they don't decay and they have a longer shelf life and they retain their efficacy and they don't develop resistance. You never hear of a chlorhexidine resistant bug, or you hardly ever hear of a it's less. Bacteria don't inherently have the ability they develop resistance, but not so much like antibiotics. Antibiotic resistance is a biological phenomenon, but here, if the disinfectant is strong enough, say like chlorine, it basically knocks off a very wide range of microorganisms. So, and the other thing is they are legal. Unlike antibiotic preparations, which you had to be very careful when marketing and licensing, I mean, disinfectants are by and large FDA approved and used in products quite commonly. Common in ones, I would say, is Chlorhexidine. Now, Hibi scrub, hand wash, Hibitane, Hibi scrub, and that's a famous brand name. In that, I have not had any money from these people, but I'll just mention some common names because you're more familiar with these things in the wards. Chlorhexidine, I think the main thing for me is that it is anti-MRSA. If you have a wound or skin which is colonized by MRSA, in fact, if you have a skin colony of MRSA, you get the person to bathe and wash the nostrils and the backside and everything with solutions of Chlorhexidine. So, and after a while, you manage to decolonize the person. Now, the moment you mix that with Chlorhexidine and cetrimide, that gives you the age-old Savlon. Now, I can remember Savlon from my father's times, and a long time ago it was there. It comes in a very strong solution. Now, please don't use the very strong solution. That is really toxic, tissue toxic, and you have to really dilute it to the correct level. Having diluted it, you have to use it within 24 hours, because once you dilute it, there's a tendency for Pseudomonas to grow inside. Old solutions of Savlon, because the cetrimide is there. But it's a useful solution, but use carefully and sparingly. I would never use it as a dressing material because it is too toxic. The annulation tissue dies in that. So Savlon, although it's good for washing, you have to wash it away and then apply whatever you're going to wash. The advantage is it is soapy. It has cetrimide, which is a detergent. Povidone has the only drawback. It's a very widely used skin cleaner, disinfectant, dressing material, blah blah, everything. It's a wonder material, and it is the only material that is available in our hospitals. Although it is rather expensive. The proprietary betadine bottles are quite expensive. We used to use tankards of betadine very liberally in our hospitals because it is available, but it is expensive. And it has a short duration of action. It gets the brown color is lost in about 2 hours if you notice. It tends in the long run to retard granulation and epithelialization both. I find that it is difficult to epithelialize a wound using betadine dressings alone because it promotes desiccation. And once it desiccates and dries off the iodine particles, it becomes a stronger solution. And the content of iodine in that is also locally quite strong, and it tends to cauterize or alter the, it inhibits the healing process. So you can go on applying betadine to a wound daily, you won't get results. And usual vehicle is gauze. So some of the materials here, and they have blacked out the Chlorhexidine here, but anyway, some of the Hibi scrub is a familiar thing, and then Savlon and the betadine, so-called. These are the major proprietary brand names. And of course, you have something about isopropyl alcohol, 75%, 70% isopropyl alcohol. It works by a osmotic effect. It draws out water from inside the bacterial cell, and it somehow kills the bacteria. The upshot of it is that it has to have a bit of a dwell time on the. You're supposed to let it dry on the skin. Scrubby. I mean, people generally don't like to use alcohol too much on chronic wounds, but I find that it doesn't really harm. I mean, I've been using it quite a lot. I have not noticed anything happening despite years of using it. Getting good results as well. I don't know, you might disagree with me, right? But then the last one, which I want to highlight is this particular boy here, Clorox. Now, that is, of course, used for, this is bleach, regular bleach. If you want your uniforms and all looking spick and span, that's Clorox bleach. But Clorox, if you dilute it to 0.25%, 1/5 of 1%, 1/4 of 1%, that becomes what is called Milton's solution. And that itself, it's one of the most potent antimicrobial agents. It has across the board coverage. It just knocks you off, knocks everybody off generally. Only thing, it is very toxic to us also, and it's sometimes you can get inhalation after a while. You do a lot of wounds, you kind of tend to get a headache, and I don't think it is good for you. I don't have real hard evidence as to the long-term side effects, but Clorox and isopropyl alcohol, if you're a regular wound care professional, be careful inhaling this, the both of them. Commonly used disinfectants continued. Now the chlorine products, the strong TCL that you use as in powder, stabilized powder form, you dilute it, you can wipe the floors with it, very cheap. You put it into swimming pools in kilos, right? And the main thing is to dilute it to the correct amount. You have Clorox Milton solution on wounds, and so on. Another less known one is Benzalkonium Fluoride. Now, if you take your toilet washing, when you wash the floor of a toilet or disinfect, sometimes even in theaters, Benzalkonium Fluoride is a very cheap and effective compound. Now, that has also found itself into certain dressing materials, cheap and effective. Again, be very careful about, if you are going to DIY and produce these solutions, be very careful diluting, because you will end up killing a lot of valuable tissue. What about Condy's solution? Now, the history of Condy's solution, potassium permanganate, is over 150 years ago. And it is very, very cheap, dirt cheap. In fact, the pharmacists find it difficult to market it because, it is so cheap. They end up making small packets. They bring kilos and put it into small packets, and they sell you. There is another issue. You can't sell more than a particular number of grams, because you can look up the YouTube and how to create a bus. It's an explosive. So in that sense, it is maybe. But Condy's, it's in the national formularies as an essential drug. In all hospitals, generally you are supposed to stock Condy's, and in very dilute quantities, it has an oxidative and across the board antimicrobial action. Needs a dwell time of about 20 minutes. It can go nicely into the cavities and work. If you have a wound, or like something like a Charcot foot where you have cavities, it's a very effective thing. You can slush it around for about half an hour. Patient will do it himself. I sometimes put it in a bag and get the person, polythene bag, and get the person to chuck the foot in. If you have a liberal number of basins, you can use it to dunk the foot in. Only thing, it ruins your basins. It stains everywhere. Floor, instruments, sink, everything gets, ceramics, everything gets oxidized and brown. It is very effective, very cheap. Nobody talks about it because the market doesn't like cheap stuff. So nobody has any research on Condy's anymore, because you can't sell it. And here is one example of another range of products called Aquasin. Now, there is a marketing of a product called Aquasin, which is recently in the market. Now, that is a chlorine-based thing. Now, age-old Milton and a couple of other compounds to made it stable, because it evaporates or dissociates and loses its action. So Aquasin in a gel form or the liquid can be used to irrigate, leave for 20 minutes, and the gel form is used in the actual wound dressing. So that is again called to the front of an old soldier, chlorine. The other one, the Revitaderm in the left, it's actually Benzalkonium Fluoride, your toilet cleaning solution in a gel form, right? In the correct concentration. And if you notice the concentrations here, right? So that's the important part. Now on to the next one. Now here is an example of a very dilute Condy's solution. If you are making Condy's in a solution, make sure that it is this color. don't store it even for half an hour. It will brown. It will become oxidized and ineffective. You can't keep a solution of condensed fluid lying around. This is the color you're targeting. You have to be able to see through it. And unless you maintain this color fresh solution, it's either useless or harmful. If you make it strong, people love to see the sort of purple color kind of diluting around in a piece of in a bucket, and you dunk it in. But you're going to stain everything from nails, keratin, everything gets stained, and the granulation gets cauterized. Some people I have seen putting condensed powder into wounds. I think you can sustain a wound in your practice for years if you use that technique. Okay, uncommonly used disinfectants. Now, well, commonly used ones he said, but in rotational dressings, we use plain old acetic acid. Now, how do you get acetic acid? You go and buy the artificial vinegar and dilute it, remember, 12 times, right? So 3% artificial vinegar contains 3% acetic acid. And of course, the stronger concentrates of acetic acid is used in the rubber industry. In fact, they used to have laborers drinking, rubber estate laborers drinking acetic acid to commit suicide. So we had a huge problem at one point. Nowadays, you don't see neither the rubber industry nor the acetic acid is available. So acetic acid in 0.3% solution is used as a dressing material when you want to combat or retard Pseudomonas growth. It doesn't kill so much, but because the acidic environment doesn't favor Pseudomonas over-colonization, it can be quite effective during the later stage of epithelialization. When you're priming a tissue, a granulation tissue, a mature granulation tissue before trying to epithelialize. Dettol, famous Dettol, is available in all the counters. It's another phenolic compound, chloroxidine. Little known thing is, again, Dettol has to be diluted. You read the label, the small print on it, it will say dilute it to how many times before you use it in a cleaning solution or whatever. So read the small print when you're using Dettol. It's not commonly used. Isopropyl oil, sorry about isopropyl alcohol, I mentioned that earlier, versus ethanol and methanol. Now, ethanol is also quite effective in 75-80% concentrations. But methanol is extremely toxic. Supposing you come across methanol, which is analytical grade, don't go near the thing. It's very toxic. What about EDTA, glycerin, ether, and solvents? I have seen people trying to take off elastoplast with ether and then washing the wound also in the same ether. I mean, no real harm, but in the long term, there is no evidence to suggest that it doesn't damage tissue. Again, ether, the problem is highly toxic and it is flammable. Be very careful. Isopropyl alcohol and ether, they are explosive, right? Explosively flammable. So don't take it anywhere near where you have a cautery equipment, like diathermy and all that. It can cause a bad fire. Now, okay. And the other thing is, when it catches fire, you don't see the flame. So the patient will slowly burn without you knowing. Okay, fine. Dressings, what are the purposes of dressings? Now, disinfectant section is over. Are there any sort of questions, burning issues which anybody wants to ask at this point? Kaushika, do you think you have anything to comment on things so far?
No, sir. So far, there aren't any questions in the chat box.
And am I going too fast, or is it clear? What do you think? I mean, is it okay?
It's all right. The pace is all right.
Pace is okay, huh? Okay. I think I might open
Excuse me, sir.
Yeah.
I'm Nirosha here. So if I interrupt, I would like to know whether, I mean, you talked about using diluted condensed now. So how about the pH value?
pH values, it's like this. I have not really read about that. The pH value, no, I really haven't read about that. I'm sorry. Condensed pH should be, no, I'll have to read about it and tell you. Did you read anything about pH of the condensed? In fact, I'll just introduce Nirosh. He's a very bright student of the science faculty. He's actually one of my MPhil students. whom I'm supervising. So his field of expertise is slightly different from ours. You're a physicist, isn't it? Your field of expertise is physics and science and physics and
Yes.
so that's a very interesting question from him from a slightly different field of it. Have you read about the pH in Condis? I haven't.
No,
It's
sir.
not. It's a corrosive, but it is not acidic as far as I know.
Yes, because I want to know, because if you are using it in a wound, you should maintain a pH value.
I wouldn't use it. I wouldn't use it for a wound dressing, Rosha, because I would use it for cleaning purposes only. I would dunk it in. I would use the dilute solution to reduce the bioburden, and then of course wash it off and then apply something neutral. I think we have used it also, isn't it, in our little practice? Yeah. Okay. Again, sir, what is the role of acetic acid in wound care? Well, that's fine. So I think I answered that. Acetic acid, it changes the pH. It changes the pH, makes it harder for certain strains of bacteria to flourish, right? Particularly the pseudomonads. But you can't go on using it, because then the biofilm and the bacterial layer, the colony, changes, and ultimately you don't get a very healthy granulation tissue at the end of it. If you go on using it daily, you end up not being able to, the use of it becomes less, effective. So shall I go on to talk about dressings, which is the sort of major part of the discussion? Shall I?
Sure.
Okay. So now, what are the purposes of a dressing? Now, you and I know that, okay, what are the purposes of a dress, right? I mean, it's about the same indication, really. You need to cover the wound, okay, to prevent all the bugs and, everything getting at it. You can get secondary damage from heat, radiation, blah, blah. You can have desiccation. You can have animals coming and biting it. I've had patients with rat bites. I've had diabetic patients coming in with very obvious rat bites, nicely coming and eating the wound, a bit of dinner supplement. So such things do happen. And then you need to cover, and then you retard colonization and infection. You need to bring down the colony of bacteria. It is a critical colonization which you have to bring down. The number of the bacterial bioburden has to be brought down. Another thing about dressing is it splints. Now, one of the ways, if a wound is painful, particularly in the extremities, if you apply a good, nice, stiff splint, your analgesic requirement becomes a little bit less. Then there's a social purpose. Now, if you have seen some children's dress, there you have pictures of favorite cartoons and all that on them. Then there are dressings which are invisible, and you can go to a party in a dressing. And I've had patients coming, regular patients coming, say, I have my son's wedding, can you do a smaller job this time? Okay, fine. Then I kind of dig into the cupboard and go and get something skin colored. So there you are. They also modify the wound bed, particularly in chronic wounds. You have to modify, or it's like maintaining a garden. If the garden is not going your way, you might have to change the pH, temperature, and moisture and all that. So they radically modify, they effectively modify the wound bed. Balance moisture, pH, electrolytes, even light, hydrostatic pressure and oxygen. I have seen a lot of wounds getting worse because of high pressure. I have come across a lot of patients coming in with very tight wound dressings, and you see rings of constriction, and worse still, even today I had a patient who had a toe wound up with the gauze, then crepe bandage, then elastoplast, and when I took off the thing, the top part of the toe was black, and he has killed his own toe. Because remember, most of these guys, they have totally neuropathic feet, and it's the dressing keeps coming off, they tie it, it swells inside, and then one fine day there is gangrene. So the dressings, right? So you need to again promote granulation and epithelialization, prevent smells, right? And so on and so forth. Now, if you take the purpose of dressings, a nice way to highlight this, I found these two pictures. Now these it's like a dress. These things are like a dress. The pretty girl wearing the corset, right, as opposed to the pregnant lady who has a modified, stretchable kind of thing, allowing growth. Now here I just put in these as a bit of a joke also to wake you up. But it highlights a key issue. If you constrict your wounds into a kind of a mold, as it were, it doesn't exactly allow you to grow very much. It's like, I mean, wounds are no different from your garden. If you stifle the plants, they won't grow. If you try to overmanage the conditions, the pH, the temperature, the pressure, and all that, ultimately you don't get results. Here, and the other thing is, this is something I tell my kids. The guys who the basic beginners, if you are training in wound care, put a dressing on a patient and put the same dressing on yourself. Keep for 48 hours until the patient comes back to you. It is like to carry that wound. The patient is why the dressing can become a huge pathology advice. Whatever the material you use, always listen to the patient. They will come and say, "Mahatya, make poda metani loose karana, metani poda kapana, make a venas karana." And don't scream at them. Don't insist on putting an elastoplast. Don't tighten the dressing obstinately because he's complaining. He has more experience with the dressing than you. Right? So basically listen to the patient. It's sometimes very, very productive. They'll be eternally grateful. And okay, materials. Starting from gauze. Gauze derives from I have misspelled. Gauze derives from Gaza. Now this is a disputed strip of land in the Palestine. That is where the gauze, open weave cotton fabric, which comes in rolls and pads. Right? It is comfortable. It's very cheap and available. Gauze is the thing which is available everywhere. Now, sterilization of gauze, there is a tendency to packet sterilize, which is very expensive. In chronic wounds, if you're running your clinic, I don't see the problem about, I don't have enough evidence to say that packet sterilization is better than batch sterilization. If you want your entire batch of gauze, have a larger packet, saves a lot of money and time. Wrapping things up and bundling them, tying them up, putting them into expensive covers, double wrapping them sometimes, putting them into the autoclave, taking them out, and rather than that, go for a big batch in one go, and then keep that safe and use a cheatal faucet to take it out. If you're going to dress for 2 or 3 hours, it's never going to make any difference. The other thing is, don't leave, even in the packets, don't leave gauze lying around too much, particularly if it has not been said, it contains a certain amount of starch. And if you keep gauze and take it out of your linen cupboard, it starts smelling funny. That is because there is fungus growing on it. So this is something for you to remember. If it has been lying around for more than 2 weeks, don't use it. Knitted versus woven. Now, the more modern types of the blue bandage particularly is a knitted fabric. It won't fray at the ends. It makes it so much easier. Now, about adhesive materials. Now, particularly in acute wounds, you tend to use adhesive materials to stick the dressing onto the surface. Now, that has its own problems because materials, most of them work because of viscosity at a microscopic level. When you apply pressure, creeps into the crevices in hold, right? The easiest, it's like these are the viscoelastic adhesives. Now, the polymer-based viscoelastic adhesives, now 3M and a lot of US companies and of course international companies have been having the absolute mastery over these compounds, and others have been copying mostly. Now, of course, everywhere they're being developed. Now, the oldest and freely available one was the zinc oxide plaster, simple sticking plaster, which came in rolls. Then of course there was Elastoplast, about 800 rupees a can, and then it's often very tacky, but the elasticity occludes a little bit, and sometimes you have to be careful using Elastoplast. Sometimes there is plaster burns happen. Repeated application removal, and it promotes eczema, dermatitis. It generally doesn't agree well with skin on the long term. Of course, you can use it in strapping. There are occasions when you have to strap wounds together or strap them open, or change the biomechanics using Elastoplast strapping. I find that useful there. Paper plaster. That's the next level in the revolution. They have some non-allergenic materials now, micropore, steripo, and all that. You can't yank it about. It is not elastic, but it is useful. And of course, a slightly different modification is the fabric, non-woven fabric plasters. There are also MIPO is one example. They allow for a certain amount of contouring. They come off very easily, particularly if you use isopropyl alcohol to take them off. And of course, towards the latter end of the spectrum, there are the less and less porous materials. Now, clear polymer sheet is waterproof. It is moisture. It's supposed to be selectively permeable to smaller molecules, but I find that when you put clear polymer sheet over exudating wounds, you're asking for trouble. It becomes a bag of pus at the end of the 12-24 hours. It becomes very difficult to handle. I never usually put clear polymer sheet dressings, however good they are, on exudating or bleeding wounds. You end up with a bag of fluid, and it promotes it's epitheliotoxic. It promotes maceration and less healing. What about splints? Now, wounds. There are certain situations where you have to immobilize for pain relief as well as healing. Bones, joints, they heal better when they are immobilized. Muscles. I have managed to, thus far, I have managed to close open knee joints using a POP cast. So I've done it on about 4 or 5 occasions in the recent past. Full POP with a window over the knee joint, which has a joint exposing cartilage and everything, and with the proper dressing and maintenance, you can get it to contract and heal, believe it or not, using casting materials. Some of the newer materials are the lighter weight Scotch cast and so on. Little note about cotton crepe, right? Crepe, there's a bit of an issue. People don't know how to use crepe often. They try to, apply maximum pressure on the wound or the skin using crepe. Crepe has to be applied stretching it to half the length, and then stretching, releasing it about halfway through. So you should not apply the full tension of the crepe onto any wound. You will cause a lot of damage, and I will crepe on anything because it can have a tourniquet effect. Okay, now going on to the more effective granulation tissue modifiers. Now, the solutions. Sometimes you have disinfectants, antibiotics, and proteolytic enzymes in the solutions. And then you have the gels. And then the sheets. Just discuss a few of the examples, right? Now, what are the solutions? Now, betadine we talked about. Savon that we talked about, I would never use them as a dressing material. Oxoferin, on the other hand, is a commercially available product which slowly donates oxygen into the wound environment. It's good for cavities, but the problem with oxoferin is it is a solution, the expensive solution, right? And you end up having to wet the gauze with it, continuously wet the gauze with it. You apply a small amount of gauze into it. You have to wet the gauze. Each time it dries off, you have to keep on wetting it. So it's an expensive way of doing things. Although you carry home a 2,500 rupee bottle of oxoferin, You can't end up putting that once in 3 days. It doesn't work. You like hypertonic saline, you have to keep irrigating the wound with it at least once or twice a day. The Condis again never used in wounds. Milton and TCL, no, unless you have this product like Aquazin or something like that, which has a gel base. Very, very small amount of chlorine compounds, hypochlorous acid and all that in solution. What about hypertonic saline? Very common in all the hospitals. What they do is they take a saline bottle and they have salt, put it into a penicillin coupé. That is the famous way of doing it. Mix the penicillin coupé to the saline bottle, and that's how they used to make it those days when we were in the peripheral hospitals. And that was betadine and hypertonic, or even betadine and hypertonic saline was the standard workhorse dressing material. It desiccates, you have to keep on wetting it, and it loses. It rapidly strikes through. I mean, what if you know what strike through means? There is a lot of exudation coming to the surface of the wound, and that is very uncomfortable. Makes the dressing heavy and unsightly. You don't want to carry around wet dressings. Okay, what about antibiotic solutions? Now there is a modern trend, particularly in less well-regulated practices, for using. It's a tempting thing to chase the antibiotic sensitivity with the antibiotic. Now there are you get pseudomonas and colonizers and coliforms which are meropenem resistant. And the reason for that is because people tend to break open the meropenem, put the powder. They sometimes get the person to buy it and bring it. They put the powder in and they apply the dressing, fine. But meropenem, even in solution, it doesn't last more than 6 hours. Maybe 24 hours, it will be totally losing its shelf life. And you can't expect it to stay on a wound for more than, be effective for more than 5 or 6 hours maximum. It's very expensive, and you will produce a nice colony of multi-resistant organisms. You get a surprise sometimes. Long-term treated chronic wounds, ulcers, they come with a very frightening antibiotic sensitivity report. It's across the board resistant to everything. And because they have been using solutions of antibiotics on top of each other for a long time. Whatever the antibiotic you use, within about 1 or 2 weeks, all the bacteria will start getting used to it. So I find that, I've also been tempted, and I've been initial practice, I have tried this also because of the availability, and it hasn't worked for me. I have stopped a long time ago. I stopped using them in any form of wound dressings. I've heard that certain people have started injecting local gentamicin solutions, vancomycin solutions into the wounds and cavities. Again, it goes against the pharmacology principles, right? So I don't know, you can find evidence for me to contrary, but I don't believe that injecting antibiotics around wounds will work. Again, coamoxiclav, break open a vial or powder it and put it in. But then this coamoxiclav anyway is unstable. Solution of coamoxiclav is light resistant, light sensitive. So I don't expect it to work on a wound surface. Right? So I generally like to frown upon misuse of antibiotics as topical therapies, except on 1 or 2. Now here is an unlicensed product which is in the market, Multisol. It has 3 antibiotics, and by Sri Lankan law it is not licensable, because you can't licensiate more than 2 molecules per compound by law in Sri Lanka. So Multisol is brought by baggage. People going overseas grab about a couple of 100 bottles of Multisol, and they can't bring home, and it's very expensive, so they make a good profit. It contains bacitracin, neomycin, and polymyxin B3, very strong topically used antibiotics in a solution or propellant, and zinc oxide. Again, I find it is very effective for about 2 weeks. After that, it loses its effect, and the strains that come after that be very, they are going to be resistant across the board to all three. So if you want to demonstrate a temporary sort of improvement in a wound, if you want to impress the patient, by all means go spraying multisol, but then the wound takes over after a while. The bacterial colony will win over after a while. And now, what about the gels? The polymer gels, the famous one is the Intracyte and the Purilon, two major companies, international companies vying for supremacy there. Intracyte Gel, they are a combination of inorganic polymers. Now, for example, it is the Intracyte Gel contains what do you call, let me see, carboxymethyl cellulose and polyethylene glycol. So those two, and then there are gel acetates and all that kind of thing. They are inorganic, essentially inorganic compounds which produces a commercially available gel. Now, if you do a little bit of now and go to the supermarket and look at what it contains. That also contains the same polyethylene glycol. Because it is toothpaste, it is not glorified toothpaste by any means. A lot of research has gone into remodulating that to fit the effect of it is different. And most of the commercially available gels are neutral products. All that they do is maintain a relatively anaerobic wound surface, relatively less aerobic wound environment, with the capacity for the wound to exchange fluids, moisture balance over a good 24 to 48 hours. That is the major revolution in using gel-based dressings. Now, that is a huge step up from your water-based solutions. Now, moment you take chlorine, the same thing, and put it into a gel, that chlorine is going to diffuse into the tissues over a longer period of time. And your dressing frequency becomes less automatically. And the effect of the material on the surface becomes more continuous. So this is the basic principle. Now, as opposed to that, you have also certain compounds like Metrogel gel. Now, that Metrogel gel, 2% Metrogel, that is an antibiotic gel. You have Clinda gel, Metrogel. So you have a lot of, I'll see a couple of chats here. So does ethanol cause local toxicity? Not so much local toxicity, but it's very absorptive as far as I know. All the alcohols, isopropyl and all, all the mucosa and skin and the wound surfaces, they will absorb it very rapidly. I feel I wouldn't advise anybody to use methanol in anything really, apart from lampu, right? Normal saline dressings, yes, again, quite neutral, but after a while, the saline content and the wound equilibrates very fast. The moment all that it does is basically, it becomes wound exudate very fast. So having wound exudate on wounds is no point having that for a long time. You're not altering, modifying anything. So for me, a normal saline dressing doesn't really do anything. Might as well put dry gauze. Then after a while, the wound will exude down to the dressing and it will be the same environment. So for me, I think I would hesitate, right? So answering a couple of quick questions there as well, right? Okay. So feel free to ask, right? Very interesting that becomes. Okay. What about the spray products? Apart from the multisol, which we described, people have devised a lot of sprays because the main reason for the spray, the convenience. Now, if you have a big on the bottom of a patient, you don't want to go anywhere near it. People don't like to go anywhere near it. You can give the spray and somebody at home can, from far away go and, put the, right? And then you can, you don't have to touch the thing very often. You don't have to go near, right? But what are the nitrocellulose in alcohol and water? This is a collodion is a very old product, right? But now you have things like Opsite spray. Opsite spray is actually a vapor permeable polymer barrier. You form a kind of a less permeable barrier on wounds. You can use that on scalp and where hair bearing areas, and where you don't want to stick plaster. You can end up spraying, right? And then of course there is this new product, the Cadmium. Now that is a prototype. It's one of the products available in the market, which is kaolin based. Kaolin means kirimati. Now kirimati again is a compound which has been used on wounds, for a long time. Purified kirimati, because it desiccates, keeps the wound surface, cooled, and and to a certain extent promotes epithelialization, because you need a cool, dry environment for epithelium to grow. Another revolutionary set of products. Now, highly that you eat, you have some gelatinate. There are things that produce gelatin. It takes water up and produces a kind of a matrix, right? And your proteoglycan matrix inside the body is also the same. Essentially, what the gel sheets, if you dry that, if your gelatin also dries, it will become smaller and minimal water inside that. On the other hand, on the other end of the spectrum, you have the alginates and in them. So you can use the more liquid gels and then gradually make it more and more solid to promote epithelialization. If you have an exudating wound, you put the one end of the spectrum like Purulon and Intracyte, and then towards epithelialization completing, if you want to promote epithelialization, you start using the sheet forms. So if you are into this is quite good. Very expensive though. If you dress a wound using these compounds, you end up having a dressing change worth about 3,000, 4,000 rupees a session just for the material. And the gel sheets are expensive. And they will sell them by the inch. What about polyurethane foam sponge? They don't react. They don't adhere to the tissues. All they do is they grab the water and imbibe the water. Now, you keep water imbibed tissue over your wound, right? But how do you get rid of the water? If you apply a wider dressing than the wound, it will travel. How practical it is, but say if you have a benzo, 10 centimeter benzo, you apply a 15 centimeter foam dressing, and the exudation comes up and spreads into the surrounding foam. Only thing, if you have a high exudating wound, within hours or less, certainly in about 24 hours, the whole thing gets saturated. Now, in that instance, you have several options. You can actually squeeze it out. Now, this is something I have practically experienced. If you're at home and if you have used polyurethane foam dressings, one thing you can do is actually take out the gauze that is covering it and reapply another gauze. What that does effectively is wring it out, like you're wringing out your sponge, rubber sponge. So that can be done if you want to save a little bit of money at home. Take out the gauze, reapply the gauze, then you wring it out, right? And you can do that many times. Because the prohibitively expensive thing is the cost, because these sheets are not expensive. Alginate is derived from algae, seaweed, and they tend to retain shape but turn into a gel. So when you put an alginate formulation into a wound, it goes in like something like candy floss and comes out. Again, you can pull it out without losing a lot of fiber, retaining in the wound, particularly in cavities. So it's a kind of a semi-soluble form of cotton wool. What about collagen? Collagen, again, it's there is a certain hypothesis that it forms a kind of a wound healing scaffolding. It's highly controversial. People have been using various forms of collagen with or without antibiotics or antiseptics, but I'm yet to see a wound kind of fill up with that. It's a scaffolding material, but I don't have any hard evidence to show that it actually promotes wound healing at all. Very expensive though. Again, alginates, they are derived from seaweed. They form they are hydrophilic, they attract water, and they maintains the form. It doesn't dissolve, so you can pull it out. It has both a wick effect and a gel effect. Now, if you know the wick effect, it draws out solution by capillary action onto the surface, as well as a gelling effect. So if you want a wick and a gel, you go ahead with alginates. Again, this is another summary about polyurethane foam. Sorry about that. It is non-adherent. It is non-adherent. It is protective to the granulation tissue and epithelium because nicely the fellows will grow underneath. It's a heat insulator as well. If you're living in a cold country, this can be quite useful because a drop in 2 degrees Celsius on a wound surface will completely stop granulation and epithelialization. This is a well-known fact. Yeah, and the rest I have described, I think. The last bit, the silver, or in certain foam dressings like Alevin AG, for example, has silver inside the wound. Now this is a common misconception. Alevin AG, for example, doesn't give silver to the wound surface. It doesn't sterilize the wound. It doesn't disinfect the wound. All it does is it sterilizes the foam, and the smell becomes less, and it neutralizes the bacteria that is coming out. Right? It's like having somebody standing outside the house, and the rogue comes out and you whack it. What goes on inside the house is their own business. Silver. Now there is a hierarchy of silver. Now silver has been, anecdotally and quite historically used as a disinfectant. Now there are the silver ions as well as the silver particles. Now the major breakthrough in silver came with development of silver in particles with and how do you make the antibacterial effect of silver more? It's by increasing the surface area. So how do you increase? You powder it. You produce a crystalline silver. It's a nano-crystalline silver. And the major flagship product of the Smith & Nephew company, that is the nano-crystalline silver. It's I haven't been paid by them, right? Their main flagship, mention trade names as well, but when you are using nanocrystalline silver, you have automatically increased the surface area. You take it in sheets. You can't use saline on it. You use distilled water to activate it, and you put the shiny side up. Now the shiny side is initially chromium colored. It is silver colored. Moment that turns gold, that means it is not working anymore. It has got oxidized. So that is how you use nanocrystalline silver dressings. But the market trend is to highlight the properties of nanocrystalline silver. They call it the magic bullet, and it will heal any wound. That is wrong. It's only effective in the latter stages of epithelialization, and it's quite effective in second-degree burns. It is quite effective in superficial, abrasions, right? Because what is most useful about silver mesh, silver nets, and silver nanocrystalline matrices is that you can leave the thing on for about 7 days. You can change the top dressing. You can change the dressing on top and leave the silver on. So what that does is you have a silver mesh underneath the epithelium is growing, and you don't disturb it. The major problem with the dressing a superficial abrasion or epithelializing wound is moment you take off whatever the material, the skin comes off. The newly formed skin keeps on coming off, right? So you create deeper and deeper wounds without actually epithelializing the surface. So in that sense, the nanocrystalline silver dressings become Acticoat. Acticoat is the flagship this product. And then the Hartmann's company, some German company, they produce something called Atroman. Atroman means it's less traumatizing to the wound. You leave the mesh on, you take the top dressing. Apart from that, the silver sulfur dioxide, the totally different effect, right? It is not the nanocrystalline effect it has. Most of the silver that is impregnated into the foams, they don't donate silver into the wound surface so much. They keep the dressing sterile, dressing less, icky-mucky. So I mean, you can sort of argue with me on this, but this is my sort of understanding and experience about the whole thing. Again, like the silver hierarchy, you have the iodine hierarchy. I mean, the problem with iodine, it gets oxidized, and it doesn't stay in its active form for very long. Betadine, only about in minutes or half an hour, it's no longer there. The effect is no longer there. Betadine ointment, it's a slightly more viscous, oily base, so it stays for another few hours. Betadine powder and spray. But iodosorb, the cadexomer iodine, is supposed to stay on the wounds for a longer time. But again, because I am not promoting these products, my analysis of it is it desiccates. Or across the board, the iodine products, they desiccate the wounds. Now, I have found that the wet tissues turn into dry tissues using this. I mean, if I really want to, if I get a vascular wound and there's amount of necrotic tissue, dry, wet gangrene and all that, moment you put iodosorb, it physically dries it off. And next time you come and see the wound, there's a lot of powder on the wound, which is no longer yellow, and the wound is sort of desiccated and it's very dry. There are situations where you need to dry the wounds. There are certain situations which that effect can be useful. But across the board, if I'm going to modify granulation tissue, I really don't like that effect very much. I find that is retardant to a certain degree. So if you're using these highly specialized dressing materials, you use them, record their effect, you get to know them very well. Right? It's like using inorganic fertilizer on your garden. Although you might get an initial growth spurt, you can start killing off your favorite plants by using the wrong thing in the wrong concentrations. So it's just like that, maintaining your garden, right? What about natural products? Now this is your ever familiar papain. Papain. Now, papain is an enzymatic debridement, naturally occurring enzymatic debridement, right? The favorite way, one of my favorite teachers actually, surgical teachers, famous surgeon, I used to work in Candy. He used to put papain in shredded form. He used to take it's very cheap, available, and we used to shred papain directly onto the wound, particularly the green, unripe papain. I found that very effective in granulating, and it debrides the tissue very fast and very effectively, and it is painless, relatively painless. I have seen a lot of wounds improving, but there is a drawback. If you go on using papain, it has a kind of a irritating effect on the granulation tissue. It will start getting inflamed. The second thing is, it doesn't promote epithelialization. They inhibit, across the board, they inhibit epithelial growth. So you have to know when to switch on and off. It takes a fair amount of experience to do this. And the other thing is, if you're putting papain, you have to see the wound at least once in 2 days minimum. Daily even, it's okay. If you're putting papain, you have to put PeMSAA. You have to see the wound at least once a day. After about 2 days, the wound becomes really unpleasant and mucky and dirty, and the PeMSAA is, again, it becomes a maluma basically, right? What are the other commercially available products? Iruxol mono, papain and urea. If you want to manufacture papain, you can put papain and urea in Vaseline base. That you can market that as a debridant, right? That is how they make the papain molecule stable by putting urea. Then you have the trypsin derivatives. You have enzymatic collagenases are there, right? And wide range of substances. Iruxol mono contains collagenase. What about this other famous thing, aloe? I find aloe gel most useful in 1st and 2nd degree burns. To cut everything short, I find that very useful in 1st and 2nd degree burns. Aloe gel, again, if you have nothing else, it is very easy. You just cut the leaf, take the middle part only, not leave the tip off, slice it down and scrape the gel straight onto the wound, right? You take the here we are. Only thing, aloe, papain and all these organic compounds, they will only last for maximum of 36 hours is about the best I can. My experience, if it goes beyond anything more than that, it is counterproductive. What about honey? This is our good. Honey is nothing new, right? You have evidence to show that honey has been discovered by all the civilizations all over the world, starting from South America to China, across the world, except in Antarctica, it has been used. Now, we rediscovered honey, and the number of companies cashing in on honey, putting various types of honey into the market. Now, for example, one company started marketing Manuka honey. Manuka honey means the honey bee usually harvests, it doesn't go far. It harvests whatever the flowers that is close by. Now, if you have a non-specific number of varieties of flowers, you call it a wild honey, right? Kaushik, am I audible? Am I?
Yes, you are audible.
Right, so if you have more than one variety of within the range of that particular honeybee, you call it a kind of a wild honey or a mixed honey. But Manuka is a New Zealand, a flower that grows in New Zealand, and some of the research was done using Manuka derived honey, and they are now marketing Manuka honey at 6,000 rupees a tiny bottle. Now that is absurd, because all the honey almost has the same effect. Now they are vying for evidence, saying that the buckwheat is better than Manuka in or the Australians in the Netherlands. They are marketing tulip honey because they have so much tulip, right? And so no brand is better than any other brand. If you go into the Cochrane collaboration, there is no evidence, right? If you go into any of the major journals, they will have no evidence of one over the other, right? So my argument is, if you are using honey, the products which they are have almost the same effect as the wild honey that is in a bottle, somewhere, you can get off a retail shop. So I don't, if you are using honey, which I don't use honey, standard, I don't use honey anymore. If you are going to use honey, no need to spend thousands and thousands of rupees on advertising and marketing. you use the common or garden honey. It's the same as what comes in a packet. The properties of honey, including an osmotic effect, moisture retaining effect, enzymatic effect, antioxidant effect, antimicrobial, anti-MRSA, growth promoting, and etc. and etc. It's a lovely product. If you have nothing else, put honey, right? You can combine gentamicin with honey, right? If you're going to combine any antibiotic, but nothing else combines very well with honey. But you really don't need to combine any antibiotics with honey. It itself produces a very good result. What about maggots? Sterile cultured arthropod larvae. These are from the blue blowfly. They are not the same as naturally occurring maggots. Now, if you find maggots inside the wound, don't leave them there saying that these are just normal. You can, some people pay for this, just leave them alone. They'll do their job. No, because if you're going to put maggots, you buy them at 6,000 rupees per 40 maggots. It comes in it gets couriered to you. You order it, and it gets couriered to you. And day 2 maggots come. You had to put it in. Day 4, you had to pick out the fellows. Because if you leave it for more, they develop a keratin layer outside on their skin, and they become rather aggressive. Right? Although they say that it is harmless, the bigger maggots can damage tissue. I have found maggots burrowing into tissues, right, and creating all kinds of trouble, particularly along tendon sheets and all that. I managed to dig out maggots from inside tendon sheets, hypermature ones in large populations, and they produce a lot of maggot stool, I think, or whatever comes out, blackish starry substance, very smelly, and again very unpleasant to the patient, because particularly in a sensate wound, large maggots crawling around inside, the patient goes mad, because they're not so the maggot therapy is not leaving just casual maggots lying around. If you're going to do maggot therapy, day 2 maggots bought, harvested and sterile straight into the wound. If you put 10 maggots have to come out. That is my theory. Right, so maggots should not die inside wounds. They sometimes, cause reactions and foreign body reactions. So be careful if you're going to use maggots. You have to know what you're doing. Okay. Controversial treatments. Have you heard that you can use placenta on wounds? And there is a gathering amount of evidence, quite unofficial evidence, that it works. Nobody has tried it because it is morally, ethically, and legally. You get into a lot of trouble. You can't run up to the Jinnob's ward, grab a placenta, and run down to the surgery unit and start cutting up pieces and just applying it on wounds. But what I've heard is this immune naive barrier, the placental barrier, is supposed to be an extremely good healing agent. In fact, there are companies which harvest the placenta, take out the cells by irradiation, sterilize it, packet it, and sell it as membranes, biological membranes. Even that, without the cellular component, that forms a very good tissue conduit. So it's something that is in the research. If anybody is interested, you can read up on it. What about cadaveric skin? Cadaveric skin can be used to cover your own grafts, skin grafts, occluded. Right? So the skin, once you put the skin graft on, it covers the lymphatic flows and the exudation, and the exudation becomes minimal on the wound. If you are running out of skin, you can put additionally cadaveric skin to guard and cover the existing the autograft. Now it never takes, because it's an allograft and it never takes. But it again modifies the granulation tissue because it has epithelial growth factor. And people say, there's no hard evidence on this, it has the same effect as having EGF. EGF in a purified form has had FDA approval as a product for promoting epithelium. So these are very interesting products, right? In the future, you might come at stem cells. Where do you get stem cells? You can get it from animals also. You can get it from placental tissue. You can get it. There are ways of harvesting stem cells from bone marrow, right? And they are immune naive, pluripotent cells. And stem cells kind of, when they came about, they thought they could sort of grow people using stem cells, grow organs, but it has kind of fallen flat. Recently, the breakthroughs have ceased to come, and you don't see a lot of products coming through anymore. What is platelet-rich plasma? PRP therapy is it has platelet-derived growth factor, promotes granulation and vascularization. So if you want PDGF and grow the granulation tissue, and then finally, if you have EGF and grow the skin, that sounds like the magic bullet, but that is really not the case, because there is no magic bullet in wound care. What about, finally, critical analysis about negative pressure wound therapy, right? That is the famous VAC. Now, the current trend is to get everything into VACable form, right? I tend to disagree, because VAC is, okay, a useful tool in certain instances, and everybody is sort of laughing about harping about how good it is, how clean it is, how wonderful it is, but it has its drawbacks. Beware of these facts. I'm not saying don't use VAC, but these are some of the things that I have come across which might, deserve a second thought. Obviously, it manipulates granulation tissue, modifies granulation tissue, promotes contracture, promotes wound closure, promotes epithelialization, and so on. It's very useful, particularly in exudative wounds, where you need to carry off a lot of secretion into a container. Particularly in deep wounds and cavities, it has had quite a good effect. But remember, moment you put a piece of foam inside a wound, plug it up with impermeable barrier, right, and put a vacuum on it, it becomes a hypoxic wound environment. That will promote anaerobic, the spread of anaerobic infection. Be very careful if you are putting onto abscesses. Don't put vacuums into abscesses, into infected joints. I never use it on bowel, despite all the promotion that goes on. That is the easiest way to create a fistula. And recently, I had this problem. I dealt with the patient who had an axillary clearance 20 years ago, and she developed a chronic wound in the axilla. And I put a VAC. Because she was exudating from that, I put a VAC, thought I could contract the cavity and come out. The exudation became tenfold. It started dripping. What had happened is I had managed to open up the lymphatic channels, which had nicely stayed sealed for 20 years. I managed to open them up and create a lymphatic fistula. I ultimately had to end up taking off the limb. It was a useless limb to start with. It was insensate and it was not working. But eventually, to get over this problem, there was no other option but to amputate the limb. So you can open up fistulas, you can open up bowels, you can open up if you don't use it properly. What I don't like is sometimes when you invite the companies to do this, the least experienced young girl or boy will come along who has no biological, no degree or no learning in biology at all. Usually a totally unqualified person comes and just follows the instructions on the bag and chucks in the polyus form and then stuffs the wound, comes out and nicely collects the money and goes off. That should not happen, right? If you're going to do it yourself, take the pack, do it properly and monitor the results, because you don't want to finally give all your credit to somebody who doesn't know how to use your very valuable tool. And overseas, of course, the nurses do it very properly. Right? They go about doing that all the time. It damages skin, right? Very badly damages skin. And the other thing is, if a wound is too yellow, be very careful when you're putting a vacuum. Now, to be a proper wound care doctor, you have to differentiate between pus, fibrin, slough, damaged or exposed tendons, and damaged or exposed adipose tissue. Now, you have to treat each one differently, right? Everything looks yellow in a wound, right? But pus you have to drain, fibrin you might have to kind of scoop off to a limit where it doesn't bleed. Slough you might have to cut out, sharp dissection, right? Or just pull off. Tendon you don't touch. You just leave it in place. Maybe scrape it a little bit on the surface. Leave it. If you cut tendons, you will have a disaster. Adipose tissue, especially in the plantar surfaces, don't touch. I have seen a lot of people just picking off. Entire farmer fat is picked out, thinking it is slough. No, wait, because it will granulate slowly if you give the correct conditions. It only follows the proper granulation tissue by a couple of weeks. Smell. Yeah, vac therapy, the other problem is if you put it in a confined space, it starts smelling bad, right? The whole place smells bad. So you need a well-ventilated space. The other thing is logistics and cost. Now, lots of vacs leak, and the moment a leak springs up, you'll be called and you'll have to reapply the vac. That's an additional cost. So my message, if you are using vac, after whatever the experience I have, I don't allow the people to come and just chuck a vac in and go off. That has never worked. I mean, if you had to do it under supervision, you have to get the patient for review. You have to monitor the progress in a very fine manner. Otherwise, you end up creating disasters. It's a very highly specialized treatment. Unless you're dedicated to putting vacuums, don't embark on ad hoc vacuum therapy. Okay, what's that? This is a vacuum. This is just a picture of a vacuum and how it works. It has to be 80 millimeters of mercury below, and it has to be continuous. So the vac machines will monitor, suck up to -80, stop, and in a little while when the pressure increase again, suck again and drop. So you will have an intermittently running motor, right? And it's not the same as putting a vacuum drain on a wound, or for that matter, putting a vacuum, the household vacuum. That is totally different, right? I mean, don't try to put the wall suction onto a wound. People I have seen trying that, right? It just doesn't work. And what are these newer methods finally, so-called newer methods? Hyperbaric oxygen, plasma ozone therapy, ultraviolet, infrared, radio frequency. A lot of very expensive, very new machines are coming into the market, right? A laser machine, which I happen to have, I had the fortune of seeing a laser machine in working in Amsterdam. They had brought it in for the exhibition. What they do is they have a huge machine, and they focus the laser, they onto the wound and keep shooting laser beams into it at random over about half an hour. What that just does is it creates microcavities in the granulation tissue, which subsequently bleed and produce more granulation tissue. To me, it sounds just like using a pin and just pricking the wound, which gives the same effect. But the machine is 20 close upon 3 or 4 million euros, right? So anyway, if you have enough money, go ahead. Ultraviolet. Sometimes you have selective color-coded gels which you apply and then apply the ultraviolet. Gel is a filter for the ultraviolet frequencies. So you get the particular nanometers ultraviolet and the infrared range right focused onto the wound. Right? So people are experimenting with that. What is plasma therapy? If you create a microcurrent, basically, if you create a arcing current between low intensity arcing current between the wound and a probe, you create what's called plasma, right? Plasma in physics, somebody doing, I think Hiroshi probably would put me straight there, right? But when you have a plasma generator shooting, electric currents onto the wound surface, it creates ozone, and ozone is supposed to be one of the best disinfectants, which works very finely and very locally. It is used for skin therapy, and recently they have started devising machines for wound therapy as well. So there are biomechanical methods. There are the intermittent suction, intermittent pumping, intermittent pulsing equipment, right? Promoting granulation, epithelialization, and so on, right? So these are in the upcoming market. I don't see anything being better than the other, except maybe hyperbaric oxygen, which buys you time, doesn't cure essentially hypoxic wounds. Relatively hypoxic wounds, ischemic wounds, you can buy a little bit of time by putting the person into a higher concentration of oxygen. Now, it's not easy because it looks like this. Now, the hyperbaric oxygen chamber is about 25 million rupees. If you want to invest, I know the contacts, go ahead and buy it. Put it somewhere. I will put the patients in. Only thing, patients have to stay inside that for about 2 hours, reading a book or something like that a day. So if you bring a hyperbaric oxygen machine, you can put 24 hours to the ambulance. Right? How are you going to recover that cost? I don't know. Right? So, I mean, out of jokes, it is not a very popular form of treatment, right? At the moment, I think there are a couple of machines in Sri Lanka, but certainly if you have some extra money, go ahead and buy one. Okay, in conclusion, will there ever be a magic bullet in wound care? To answer so far, after doing so many years of wound care, it's like the question of whether there is a perfect wound care material is like asking whether there is a perfect fertilizer for my garden, right? I have so many types of flowers, I have so many types of plants, I have grass, I have polgas, I have dilgas, right? You have to treat them differently. Some fellows like sunlight, some fellows don't like sunlight. Some people, wound care is something like that. What it requires is, repeated assessment and very, very attentive type of treatment, giving attention to details and looking at the wound at least 3 times a week, right? You need continuous assessment and therapy, and then only you start getting good results, whatever you use. So my message for you today is probably, after having told you about a lot of, trade names and all that, there is nothing that can replace good attention, good insight and care, right? The other thing is, a famous teacher of mine kept on telling me, right? Again, in Kandy, he was my boss in Kandy. A wound is merely a manifestation of systemic disease. That is absolutely correct. To this date, this is the mantra that I follow. If you find a wound on a patient, ignore the wound, treat the patient, right? Or wound will automatically heal, right? Because no amount of debriding, picking off small things and changing the dressing types, pH, and all that is very important. I know, but that can be done at an outpatient level. And if you really want to cure a person, put him back on his feet, make him stronger and fatter and active. You can't apply anything on a wound and get results. So treat the patient, not the wound. And bear in mind that sometimes in the market, you're very tempted to use this product, that product, and everything else. Most popular therapies are the ones that sell best, right? If you can earn more money selling a particular product, that product will be anyway in the market. So learn a little reality about these things. They are not useless. They are all quite useless, useful in their own way. But be aware and study them. It's fascinating. Of all the work that I have been doing, this wound care has been, grabbing my, interest more and more each day. So I hope, I managed to give you some insight, a little bit of insight over these few minutes and hours. I would like to thank the PeMSAA for inviting a guy like me to talk about a small area in wound management, but I hope you have got some insight into things that you might not have thought about or known about before. So thank you so much, the PeMSAA, my own faculty, and my especially my teachers, right? My surgical teachers like Dr. R.J. Kiseniratne, Dr. Professor Galkatia. I really appreciate them. Professor Hare from Wales, who was my mentor there, and Professor Ratnatunga. I mean, I can't start naming I can't praise them enough. They have sort of set the stage for everything. They say that when you stand on the shoulders of giants, you can see very far. So that is what I'm seeing right now. Right? Then of course my colleagues, friends, and my family, and above, they have been very supportive of all my efforts. Right? And above all, the most important teachers for you and for me have been my patients. Some of them have lived and died under my care. I appreciate every last one of them for teaching me at least a little bit more about wounds and life in general. Thank you so much. And over to you, Kaushika. I hope I'll have some feedback.
Yes, sir. Thank you very much for that very informative lecture on wound care dressings and all the new stuff that is available in the market. And you gave a very good insight about how to use them, and like as you said in your last few slides, the most popular ones are that sells the best. So I think that's very true, and like we have also seen a lot of products that are in lot of wound care products in the market, but those are especially the ones that are ones that sell very much, and like though they have been in use for recent times, but I think the good old methods do also work. So that's the message. I mean, one message that you gave us today. And also, sir, would you like to accommodate any questions? I think in the chat box, of course, they don't have any questions. If you
so
have,
I've got some.
do you have? I think they must have directly
welcome.
messaged you. I can't see any questions in my chat box.
No questions as such. I mean, quite a few people have been so nice to thank me, and I thank you, right? For let me see this methanol, blah blah blah. Thank you so much. Okay.
In that.
Yeah.
So if you have any questions, you all can unmute yourselves and ask from Dr. Manjula. So in the absence of any other questions, may I ask you one question, sir? Like honey dressings, sir, like when would you kind of advocate on them? Like is it like as a last resort, like when everything has failed, you just try it?
No, not at all. What you have to remember is when you have to use them. Now, honey, for me, has a, let me see, acute patient with an acute wounds, there is no role, right? Acute wounds, right? But in chronic wounds, during the initial phase where they are either septic, where you have systemic sepsis and a huge bacterial bioburden, you might have multi-organ failure and such and such. Again, I would not dare use honey, right? Because at that point, the wounds and the tissue loss and the wounds and the infection is well perfused, and there is really no role for honey and such. But when it is starting, the patient is stabilizing and the wound is starting to stabilize, honey has this effect of reducing the local bacterial bioburden, right? So that is probably when I might, think about using honey. Having said that, you have better products as well. Now, at that point, when you want to really kill off the microorganisms, I would use something like the chlorine-based products, right? And Hibitane, the Chlorhexidine-based ones, or even the iodine preparations. Now, having got that out of the way, now, if you have fairly good granulation tissue, if you want to really grow the granulation tissue and ensure that the moisture balance is retained, and if you want to save a little bit of money also, honey seems to be one of the best options, because at that point, if you run out of cash and if you can only find some gauze and honey, it's a very good option. I think one of my colleagues who was working in Rikilagaskada, he's a very close friend of mine. He advocates the use of honey. He has done a lot of research on it as well. Because he was in Rikilagaskada and Tirudini at some point, I think, I mean, you have to think about the people you're treating. You can't get them to afford 1,000 rupee, 5,000 rupee materials, right? You're back against the wall. You have nothing in the cupboard. And honey fills that gap marvelously, right? Provided you apply it daily or every other day max. Honey, papain, and those things can be very, very valuable. The only reason why I don't use honey very much now is that honey is a little bit difficult to find in good quality. And at the moment, I have some compounds which are slightly better. I mean, they behave better, they have been giving better results, so I have kind of laid off. For a long time, I used to use honey almost exclusively. A vehicle for honey, you can use it with alginates, sorbelgon and honey. You can use it with gauze and honey. And I mean, there are quite a few good applications. It is not toxic to the skin, right? And contrary to common belief, kumbikala marenne. And in fact, in a good quality honey, it doesn't attract ants for some reason. You know, it's very surprising.
The concentration of the sugar content.
Also, I think it has some toxic materials that the bee secretes into it. I mean, obviously, I mean, you would have ants infesting the bee's nest, no? So obviously, there is something to drive them off. Nobody really knows all the compounds that are there in honey. And, yeah, it's a product which has to have more research.
Right.
Anyway, I hope that answers your question.
Yes. Thank you very much. Seems like they don't have much questions today.
Nirosh, how do you enjoy? You're a guy slightly outside our circle of expertise and a different profession altogether?
Yes, of course. It was quite interesting, and I learned few things. I jot down few points as well, so I would like to discuss it with you later.
Yeah, we will have a quiet discussion. Yes,
so I mean,
very special connection there across disciplines connection.
As you said, I mean, these things are really interesting to know. I mean, whether you go through them in a professional manner or not, it's good to know these things, because like every day you will see at least a person with some sort of a wound. And so because of that, just knowing a part of it is, I think it's very much a requirement, so that people can work them with an understanding. As you said, I mean, in a treatment, you know what the doctor is doing to you, and you guide yourself in a good track. So otherwise, you might be anything like, I mean, adding condis to an open wound, and it gets worse.
We have some experience there.
So, in a basic manner, it's good to know the science behind wound, and to educate yourself, so that it would be beneficial for you for your entire life.
True.
So thank you, sir, for inviting me.
Welcome. Particularly wanted your own word. Yeah, thanks. Thank you.
Thank you.
Kaushika, then I think we can wind up the session.
Yes, sir. Yes. So in the absence of any further questions, I think we have had a very informative lecture. So thank you very much, sir, for giving a lot of insight about wound care management and for spending your valuable time with us and sharing your knowledge on wound care management. So thank you very much, sir. On behalf of the PeMSAA Council, I would again like to thank Dr. Manjula Peiris for conducting this lecture, and I would also like to thank the Council of PeMSAA for organizing this lecture series. So good night, everyone.
Good night.
Thank you.